Candace Hodgkins, CEO of Gateway Community Services in Jacksonville, Florida. Gary Mendell, founder and CEO of Shatterproof in New York City. And Evita Morin, CEO of Rise Recovery in San Antonio, Texas. A reminder to our Zoom attendees that we will take 3 snap polls during the show and we'll announce results, and questions submitted through the Q&A function at the bottom of your screen will be included in our discussion. Thank you all for joining us. It's just wonderful that you're here to talk about addiction. We took a look at the National Survey on Drug Use and Health, and there are about 20 million, or about 6% of Americans over the age of 12 battle substance use. And so let's talk about how this manifests in these various regions. We have Florida, we have Texas, San Antonio, Texas, the heart of Texas. We have New York City. Candy, let's start with you in Florida. How does addiction manifest in your region?
Well, first, let me thank you very much for having me here today. And it's very wonderful to be with Gary and Evita, colleagues in our addiction services protocols. So in Florida, the opioid crisis that started back in 2016 has really hit us hard. And so I would say opioids is the major drug in the state of Florida, as well as in Jacksonville, followed by alcohol, cocaine, and then marijuana. So we're trying to deal with it the best way we can. My organization, Gateway Community Services, has been in Jacksonville for the last 40 years, and we treat adolescents and adults, and we have a comprehensive program that goes from detox all the way to recovery housing with all the services in between. So we treat about 5,000 or more individual people a year, and that equals about 190,000 services across the board. So our job and our mission for Gateway is to help people with addictions and co-occurring mental health disorders. And it's a big job, and we're successful, but it takes a lot of work, and not everybody is successful, as anybody who's in the addiction field knows. We suffer from people who are unwilling to get treatment, or somehow, for whatever reason, they just can't get it, and either end up using again, or perhaps dying, which is what the opioid crisis has really increased in our community, is death.
And I think what's so frustrating about drug use in the United States is that so much of it is part of a business model that leads into addiction, right? Particularly the opioid arena has received a lot of press coverage, but alcohol is also a business model that leads to addiction. And some of these other drugs that end up becoming real problems start off as over-the-counter medication, and then are manufactured into other issues. Gary, how are you finding this in New York? How are you experiencing this epidemic? Is it also opioids as it is in Candy's area in Jacksonville?
Sure. Let me start out by saying that my organization, Shatterproof, is less focused on a particular area. And we are in the New York area, our corporate office, but we're doing work all over the country. So it's really nationally the way I'm looking at it. And so if I can answer for that, nationally, there's no question that the opiate epidemic continues to rage, tragically. Other substances, including alcohol and all other substances, are also more in use now than they ever have been. In the month of May, there was data that showed that overdoses across the country, back to the opiate epidemic for a second, overdoses across the country were 42% higher than they were May 2019, month over month, year over year.
42% higher.
42%. And that is before I even saw that data, or I'm sure Candy or Evita or any of us saw that data, we all expected it. I mean, with the opiate epidemic, think about the social isolation that people who are addicted feel. So much worse for them than, or someone with mental health issues. It's hard for everyone, but think about someone who has mental health and or addiction issues. the impact on them. Think about the impact of the anxiety that comes with worrying if you're going to lose your job, or if you lose your job, how am I going to live or eat? That anxiety that comes with that. Can I get to my treatment program? Can I go to AA meetings or NA meetings? I know a lot of them are through Zoom now, but I just spoke to someone this morning who said it's just not quite as good. You know, we've had half a dozen overdoses over the last 6 months in my greater network here in the New York area related to, you know, I don't know that it would have been zero a year ago, but it was clearly more now than it was a year ago.
And the interaction between stress, right, trauma, mental health issues, and we talk about mental health. We all live with mental health issues. And it's really a question of how do we deal with it? And sometimes self-medication is the exit from that trauma, temporary, but it has amazingly poor impacts on us. Evita, are you finding that as well, that the stress of the COVID situation, as Gary said, the threat of losing jobs, the social isolation, is this also what you're encountering in San Antonio?
Sure. I think nationally, we're all seeing that isolation has a negative impact on mental health and behavioral health, that loss of income has a negative impact on mental and social health. And as a result of that, I think I see people either relapsing or introducing drugs or alcohol to placate their nerves and their circumstantial depression or anxiety, but also losing hope and having quite a bit of despair around their own futures. And so we do see that in San Antonio as well as, throughout our communities. I think in San Antonio, our biggest challenges, and I can't speak for other communities, but I do see I would guess that there's some parallels, that the behavioral health system is disjointed. I can go into a hospital for any number of ills, my physical health, and I know I'll be treated. But if I may not be using the type of drug that this, a treatment facility works with, or I might not be the right gender, I might not be the right age. And so there are so many limitations with access to care that create these silos and make it very difficult for people to receive help that need it. And so there is that gap in our community. There's also an overwhelming neglect of youth who are struggling with substance use disorders or misuse. I think we are past the point of, I think we all recognize that Just Say No is missing something, but we haven't really replaced that well enough with Just Say No, KNOW, to the people that are youth that are already engaging in drugs and alcohol. We need them to understand the impact of their choices. We need to acknowledge that they're already making those choices, and that the likeliness that they're doing it right now with idle hands is increasing. And I think that we're in a place where we have to face that reality that you mentioned. Age 12, around age 12 is when this starts. And yet oftentimes we're not addressing it until well after they're in their late 20s, their early 30s. That's much too late, and we need to be addressing it much sooner.
There's also this really interesting dichotomy. We just completed a poll in which we said, do you consider drug and alcohol use and dependency to be a treatable disease, with the implication that it is a disease? And 87% of the people believed that it was a disease and treatable. There are a few people who were not sure and a few people who didn't believe that. But let's say it is. There is this disparity between the kind of treatment that insurance will cover and that we are set up to provide. There is very often no integrated approach in which you have both the physical and the mental health aspects treated in a holistic way. So sometimes the treatment for the physical ailment can result in the prescription of a substance that can tip into addiction. How do you see the changes that society needs to make in order to place addiction front and center with other ailments, whether physical, a broken arm, or mental health, very obvious mental health issues? how do we actually deal with this and remove the stigma and start to treat our friends, our family, and our fellow citizens? Candy, you want to give a cut on that, or Gary, Evita?
Sure, I'll start. Stigma is the the biggest obstacle that we've always had with treating mental health and substance use disorders. Breaking down the stigma, chipping away. We're doing a good job. It's better than it was 10 or 15, 20 years ago, but we're not there yet. And we need to educate and keep sounding to our legislators that these disorders are needed to be treated just as all physical disorders are, and that they should all be treated together, and treatment should not be something that people have a difficult time accessing. And that the reason, the 12-year-old and teenagers are going to experiment, but the reality is in our families, it's still a stigma to talk about it. You don't want your child to have a substance use or mental health disorder. And so the denial is very strong, and that also adds to the difficulty in breaking it down. So it really just needs to become a national effort, a statewide effort to break the stigma so that people know it's okay to get help. Ask for help early. Teach your children about substance use and mental health disorders. We all have mental health stuff.
Does stigma have a business use for, we're talking about a field where people earn a lot of money, and insurance coverage is expensive, care is expensive, and profit is so often, or at least a positive cash flow is so often the priority. Does stigma actually have a use in that you keep a certain amount of very expensive care off the market because it's difficult to fund?
Yeah, I'll jump in. Shatterproof is working on, all our work is centered around 3 pillars, if you will. The first pillar, and you've touched upon it, Mark, and obviously, and so did Candy and Evita, is the treatment system in the United States is not where it needs to be. So that's pillar number 1, transforming the treatment system in the United States. Pillar number 2 is we need to remove the stigma associated with this disease, those who have this disease, and the medications that treat this disease. And number 3, we need to provide information and support and resources to families so they can understand this disease and have the information at their fingertips. All 3 of these, I'll add a few words, just like any other disease. And so to transform the treatment system in the United States, and all of you have touched upon in the last few minutes, is we have a 5-point plan to do so, which we're leading around the country. Number 1, one national standard of care. And there are dozens of evidence-based practices, but what we did 3 years ago was boil it down to less than 10 core principles of care that should be reflected in any treatment program in the United States, whether it's alcohol or opioids, whether it's adolescent, adult, whether it's residential or outpatient. 8 principles of care, which we published 3 years ago and have gained broad industry acceptance around the country. And it absolutely encompasses what Candy and Evita have said. Coordinated care, not just treating you for addiction, but also mental health and physical issues. There's 8 principles of care, and it's on our website. So that's number 1. Number 2, we need to get people to treatment programs. We need to publish on an annual basis the quality that's being delivered at treatment programs, tracking, crosswalking consistency with our principles of care, and get that information out transparently to payers, consumers, to states, all 3 of which will drive demand to the higher quality treatment programs, which will, Adam Smith, very simple, the invisible hand. If demand is driving from consumers, payers, and states to higher quality care, because the information is transparent, it will absolutely increase the quality of care. And also,
Gary, what happens if
but also giving that information to providers, to treatment programs, so they can learn from each other. I mean, I just want to just say one last point on this is my experience in the field with my son, and then since then, you read the articles about unscrupulous treatment providers. That's the rarity. Most people in this field are wonderful people trying to help people. The field was behind in giving quality information out of what should be delivered. There's a lot of old beliefs. And if we can get this information out, as I said, to payers, states, and consumers to drive demand, and information out to providers so they can benchmark against each other and learn from each other, the whole treatment system will improve. And that's what we're doing. We just launched a quality measurement system a month ago. I'm sorry, Mark, go ahead.
No. I'm sorry for interrupting you. The reason that I was so bold to do so is that third point that you mentioned, which is the resource point. Because Adam Smith kind of breaks down when there are no resources that can inform the market. The market is great where resource, in other words, money, becomes the communication mechanism for it to align itself. But we already know that the need is so intense, particularly amongst communities that suffer a lot of trauma through poverty or transgenerational economic dislocation, often communities of color. So the demand is manifestly there, has been for decades, but the resources haven't been. And so the market doesn't organize that organizing principle that you point out. It doesn't organize around people who with no resource. How do we deal with that? We do have this, the government response pejoratively referred to as income redistribution, right? How do we deal with that in a way that does create that one standard, does allow people who have addiction but no resource to find treatment? And I don't have an answer.
Well, I do. I mean, it depends. When you say resource, are we talking about dollars or are we talking about information? So let's talk about, okay, dollars.
Yeah.
Okay, so dollars, the reality is most people in this country, the vast majority, are on health insurance or Medicaid health insurance. And the little secret here, it's not much of a secret, but the fact is that treating a patient with quality care is much less expensive to a payer and insurer, whether it's Medicaid or commercial, than have someone treated at a treatment program that is not delivering treatment based on evidence-based practices. And so it's much less expensive, not more expensive. And so if we can get this information out, not if, we're doing it right now. We just launched it in 6 states and it's now expanding to other states. Get this information out to families so they can see where to go, or they go to their insurance company and it has network information, who's covered. And if payers are using our information to help in their decision of who's in their network or not, it's going to lower cost. It's not going to increase cost, lower it dramatically. And we have data that shows it. So this is not a dollar issue. This is an information issue. And so getting this information right now on our website, anybody in the country can go and learn, any patient or family member can go on our website on Atlas, at treatmentatlas.org, and learn about what you should be looking for in a treatment program. And then if they happen to be in one of the 6 states that we have quality information, they can just click a button and see all the quality information. They don't have to ask and figure it out. It's all there.
Evita, what are your observations on this issue? Is it in your area in terms of ensuring that people organize around effective treatment? Is it an information issue? Is it a resource issue? I
think what I've been thinking about in this conversation is that there is stigma, and there's questions about whether or not, or perspectives about whether or not it's a disease or it's a moral failing. All of that, to me, matters less than that addiction is an underlying cause of so many social ills that our communities are interested in changing. And they may not be interested in changing addiction, but I know they're interested in changing family violence rates. I know they're interested in changing student success. I know they're interested in changing so many other homelessness, and drugs and alcohol continue to be risk factors for all of these things. And so I think it's changing the conversation in some ways and ensuring that people are aware that addressing addiction with evidence-based practices will result in better outcomes for quality of life in our communities. And I also think that we're not just disjointed on the ground, but also in the conversations around behavioral health and mental health. I continue to find myself in rooms that are strictly behavioral health people, the other addiction folks, and then people in the mental health field as though they are not the same. And trying to bridge that gap and add behavioral health to every mental health conversation, and particularly youth mental health conversations, is a critical game changer in us having what we need at Rise Recovery to get the resources to the youth that we serve. At Rise, our focus is on youth, young adults, and families, because that's where it starts. Time and time again, data supports that if we address this and not just try and prevent it from never happening, but admit that it's happening and work on with youth who are already engaging in drugs and alcohol and adults, we will reverse so many social ills for that generation to come. And so our focus is on that through the use of peers. I'm very curious, Gary, what's your pillars? I'll be looking into those, because our work is, I'm a social worker by trade, and I think where I found really incredible motivating factors for change for the people that we serve was in having a trained, licensed person with shared experience walk along and create that navigation, create that that hand-to-hand transition to continuum of care, and that support that's missing in a highly stigmatized disease. And so I'm curious what your thoughts are there.
Well, just to add one point, you mentioned a couple times highly stigmatized disease. First of all, I agree with you, everything you said 100%. But if I can pick up on your comment about highly stigmatized disease, this is not rocket science to reduce the stigma of addiction. We spent 9 months last year working with a team at McKinsey, and we studied 11 analogous social movements where change was created. And we pulled out what were the key success factors. And the action items that need to happen to reduce stigma, it's 3 simple things. It's educating in a certain way with people with lived experience, sharing their story with those without lived experience. And that sharing of story has to be one of 2 messages. It either has to be a story about themselves in successful recovery, and this is what I look like, and this is a treatable disease. Right. Not that it's a disease. Shatterproof was doing it wrong for a couple of years until we learned. We don't want to educate people it's a disease, because you still don't want have anything to do with anybody who has a disease. You want to educate people it's a treatable disease. And I have been treated, because there's evidence-based treatments, at the same success rate as someone with diabetes, asthma, or heart disease. And here's what I look like. And I have a family, and I go to church or synagogue or wherever I go, and I have 3 kids, and I coach Little League, and this is what I look like.
Well, it's information that leads to a solution, right? That leads to an action, right? It's not just information that's neutral.
And we need
can I piggyback on you, Gary, for a minute about peers? And what Evita brought up is that peers who have the lived experience and can meet with a patient, which we do in the ED, they have such a connection with people because they're sharing their life story, their lived experience about, look, I was where you were at one point in my life, and now I'm here. And the person opens up to the peer more so than they would ever open up to the doctor in the ED or a social worker, a licensed mental health counselor like I am. Peers are the key to success and recovery. And we've proven that in Jacksonville with our Project Save Lives with the overdose population. In the ED, meeting them and doing the warm handoff to a treatment provider so that they're being followed by the peers. And sometimes they don't even get into traditional treatment. They just have the peers be with them for 2 or 3 months or longer, depending on the person. And the success rate and the reduction in deaths is amazing. Since November 2017, we've had 1,200 people that have consented to services, and only 6 have died from an overdose, where they were coming in over and over and over again into the emergency department. So you're right, Evita and Gary, that is the key, and I think you're really on to something, and we need more of that in our addiction and mental health treatment.
And 87% of the people who responded to our last poll felt that voluntary outpatient counseling, which is what we're talking about. We're talking about people-to-people support groups, which is in itself an empowering act. When you can talk about your own experience, share that with others, and feel like you're having an effect, that is an empowering act. It's part of recovery. In helping others to recover, you're recovering yourself. There are some other issues here that were begged. We've been asked a question about, and I guess this deals with some of the issues that you're talking about, is it necessary to take a legislative approach or a full-on federal approach of trying to shift policy in order to get us all rowing in one direction in this country to deal with some of these different issues, the disparities between physical and mental and addictive health treatments, the whole issue of rowing together. Gary, you were talking about the whole information problem and how that could actually resolve the resource allocation problem, because it's logical to take a least cost solution than the high cost ineffective solution that we're taking now. What do you think? Or is this the kind of thing where we have to have a federal kind of federalist kind of an approach where each state does its own thing because each state is different? What do you all think? And you all represent these very different parts of America. What do you think? Evita, what do you think? Do you think there should be a national policy or a Texas-wide policy or just a San Antonio regional policy?
I think the brain needs to be a part of the body. Last I checked, it was, and I think
we're having some difficulty with your audio.
Sorry about that. I was saying that the brain needs to be a part of the body.
We can't hear you. Let me talk with Gary, and then Candy, and maybe we can get your audio back in tune. Gary, what do you think?
Related to transforming the treatment system and related to ending the stigma, it's a question. My answer is, of course, the federal government can help. Absolutely. But we don't have to have the federal government. It's just going to take slower. Anytime you go state by state by state, it can be done, but it'll take a decade versus the federal government can help all of us get this done in a year or two much faster. So that's the answer.
So maybe it's an organizing principle where you bring people together and you find a consensus, and maybe it's not a coercive process of the federal government, but it's an organizing process. Candy, what do you think?
I would agree with Gary. Having the federal government, they've been very helpful in the opioid crisis in the state of Florida. I'm assuming in New York and Texas also, in providing dollars for treatment and outreach and prevention. And it goes faster when you have the resources, which I'm sorry, it's always the funding, the money drives the system. But I think you have to have the feds as well as the state and as well as your individual communities. And because bureaucracy is hard to move quickly, as we all know. So I think sometimes the grassroots effort of the communities that get together, the providers that get together and say, okay, this is what we need to do. And then we basically ask our legislators to help us do that by showing the results. There's got to be a return on investment if you're going to get funding from any philanthropist or governmental entity. And
Evita, let's try you again. Can
you hear me at all? No.
No, it's really poor. I'll tell you what. Why don't you use the Q&A function to type out your points, and then I'll read them. I'm sorry about the issue here.
That's okay.
we were just doing another poll, and we asked what people thought the leading cause of drug dependency was, and we forced everybody to pick one. And what's really interesting here is that stress and self-medication, which are points that you've all made, had about a third of respondents agreeing, as well as living in an environment where drug use is common and accepted. And then there were other pretty significant responses: biology, lack of education on the dangers of taking drugs. What was interesting is we got 0 respondents saying that the issue is lack of self-discipline. In other words, we seem to be shifting. Remember how people would say, oh, they're addicted to alcohol, it's their fault, they don't have discipline, right? They're addicted to drugs, they don't have discipline. You would victim blame in many cases. It seems like we're evolving in part due to your efforts. How do we continue this shift? And I'm going to ask everybody to sort of make a last point. Evita, if you could type, that would be great. And Candy, and then Gary, and then I'll read out Evita's point as well.
So, my last point is that we have made progress. It's been slow, but we need to keep educating. We need to keep providing evidence-based practices. We need to keep, working in our communities and really being out there and being vocal. I think that's why things have changed, because we started being more vocal than we were 20 years ago, 40 years ago, when it was like, oh, if you have an addiction, mental health, don't say anything to anybody. So we just have to keep doing more of that. And I think, Gary's program and Evita's working with the youth. I mean, I think we're all really working in our own areas to make sure that it becomes more cohesive and that we make a bigger impact down the road.
And Gary, how do you think we can shift this? I know you have your own programs, but if you were to call everyone to action, what would your call to action be?
3 things. Number 1, when you say we have our own program, we don't run a treatment program. We're working on things behind the scenes. We're working on transformational change for the entire system in the country. And so to do so, we need to expand quick. We just launched in 6 states quality information. This needs to be in every state across the country. And whether we pick up a few states a year or we get it all done in a couple of years and get this information out to families so they have it, that's what we need to do. There are treatment programs all across the country doing really good things, doing everything the right way, and there's many that aren't. And so we need to get this information out so everyone will see what needs to be done and just transform the system fairly quickly. And payment models will go with that, because treatment that's based on quality is much less expensive with much higher outcomes for patients. Number 2, I mentioned 3 things. Number 2, stigma. We can do this over a couple decades, or we can do it quicker. People can learn about it. This is not a self-promotion, so go to any others if you want to do it. It doesn't have to be us, but we are building a national effort all on reducing stigma based on 3 things: educating in a certain way, changing our language, and number 3, change in policies. And then the 3rd pillar is we need to get this information out to families so they understand it. People, if they have diabetes, they know enough. And if they don't know, they can go to their primary care doctor and he knows, he or she. But they don't know, but our country doesn't know about this disease. So we need to give the information in consumer-friendly language to families so they understand how to prevent and treat and recover from this disease. All doable quickly, not over decades.
Evita, I don't know whether let's try one more time. Can you? No, we can't. We can't hear you. So let me just make a point that I think you would want to make. 6% of Americans over 12 suffer from substance use and addiction. 6%. If 6% of our friends and family suffered from cancer, we would want them to have treatment. We would want to address it. And you know something? 6% of our family and friends are addicted and do use drugs. We just don't know it, maybe, but we will know it eventually. So that's what we need to do. We need to act as if that's happening today, because it is. Thank you all so much for helping us to understand this really important problem. Evita, we're going to come back to you, and we're going to do a nonprofit spotlight on your organization so that we ensure that we can unfold your story. I'm sorry about the audio problems. That's part and parcel of live television. So thank you so much, Candace Hodgkins, Gary Mendell, and Evita Morin for your insights on addiction. And please, everybody, stay safe. That's the Nonprofit Report. And have a great day. We'll see you on Thursday again at 8 o'clock.